Thank you, Dr. Govil, Dr. Anand, and welcome to the ever popular 11th refresher course. It's a privilege to talk here on the job I routinely do, traumatic brain injury. Management of TBI is very simple, but the problem is simple things don't get done. So let's have a quick recapitulate of what needs to be done when a TBI patient comes to you in a specialist or a standard ICU. I've been greetings from my place. No conflicts of interest. The problem of TBI in India is that it's a huge issue. Our registries are incomplete, our data isn't there, but if you have to believe some figures, every 5 to 7 minutes we lose one person in India to a polytrauma. Some of them would be TBI. So that's a huge figure. And we have the dubious distinction of being the head injury capital of the world. And we don't have much national strategies to manage that, unfortunately. Management of head injury, I would say our primary aim is, you'll hear this again and again, is to prevent secondary brain injury because the primary brain injury gets done at the scene. There used to be an old way where you'd say go to the nearest hospital, but now with so many neurocenters coming up, also within our country, with more metros coming up, you don't actually need to go to the nearest hospital. You should, our pre-hospital study needs to think if the equidistant neuro center exists, then we need to get to the equidistant neuro center. So the new way is that you need to get to a neuro center which has a dedicated 24-hour CT scan, dedicated integrated neurosciences services, both intervention, neurosurgical, a dedicated ICU with a good integrated neuro rehab that gives you a better outcome. So this chain of survival as a neuroanesthetist or a neurointensivist, it doesn't start when you get when the patient reaches your ICU. It starts when you first get onto the patient. That might be in the community. There are very good centers down the south who would have a robust pre-hospital system now. Things like stroke are being managed in pre-hospital CT scans. So is TBI being managed very beautifully. So the neurocritical care TBI management starts if you get the patient at site, in the transport or in the emergency department, of course in the ICU. But the management starts when you first get your hands onto the patient, not when the patient comes to you in the ICU. So that chain of survival is influenced by how soon the patient's treatment is initiated. And I said the neurocenters do make a difference. So again, this is Western data. We don't have our data, but we have about 2.5 times almost an odds ratio of an improved mortality if the TBI is managed at a dedicated neurocenter. Enough data to support that now. So our aim is to prevent secondary brain injury. The TBI can be multifocal, it can be a diffuse axonal injury, it can be an operative one like an extradural or a major subdural, it can be a penetrating skull fracture or an injury like that. But the primary insult has happened. So our job as physicians is to minimize the secondary brain injury that can start from within minutes of the first injury or maybe hours or maybe a couple of days after that. And the common denominator of that secondary brain injury is two main things, hypoxia and hypotension. There are other factors, but these two are the main ones. If you can control the hypoxia and the hypotension in the subsequent time for a TBI, you would have probably done better for the patient for 80% of our cases. So these elevation of ICP, respiratory dysfunction, cardiac dysfunction, fall in blood pressure, metabolic derangements, they all add up to the secondary brain injuries. So our treatment goal is to get as much normo in our ICU for that patient for possible. Intracranial pressure management, ICP management becomes a textbook topic because we don't practice actual ICP measurement in our country as often as we should do, apart from few hospitals that you can count on one hand, which do it purely for research purposes. So that's why you don't know the actual ICP. You assume the ICP high. You assume that the perfusion brain tissue oxygenation is low because we don't measure it. So we do surrogate measures to get the ICP down, CPP up, improve oxygenation. So these are the good, general good ICU parameters that you need to do. continuous resuscitation evaluation of an acute patient, the overall extent of the injury. But the most important thing for a patient that comes acutely straight to you without an A&E is to make sure that they do not have an exsanguinating extracranial injury. So if a polytrauma patient comes with a TBI, your first and foremost job is to make sure that there are no life-threatening non-cranial injuries, be it a long limb fracture, be it a major pelvis, chest or an abdomen. We cannot take it lightly, because no matter what you do to the brain, if the patient is oozing from a long bone in the femur, if he's got a crushed pelvis, if he's got an undiagnosed, untreated rib fractures with a hemopneumo, that patient will desaturate and it will worsen the ICP. That patient will bleed and worsen the ICP no matter what you're going to do to the brain. So those things are extremely, extremely important what is initially done. So the assessment and the treatment of extracranial injuries or hemorrhagic shock is paramount before we set on to manage TBI on its own. Let's say a very small case, a 24-year-old man comes brought straight to the ICU, let's not say to the ET, road traffic accident, he's groaning in pain, his face is covered with blood, he gets a sketchy history is given to you that he's been hit by a car, he was a pedestrian. So from this image that you get from the patient, what is the first step that needs to be done for this patient? Absolutely, great. So I think we're doing very well. He needs to be managed by an ABCD approach. So we know his groaning is A is okay, we do your basic BCD, but what's the next investigation if you think that he's covered in blood is required? So we take him, if he is stable in his ABC parameters, the D&E, you take him for a CT scan. That's the first investigation. There are guidelines that's if the patient is stable, you get that done within the first 20 minutes to triage him further. Now, if that's a polytrauma scenario, you do the entire trauma protocol, which you should be in your hospitals well versed with your radiology department. In the same run, you get the recons of the head, the cervical spine, the chest, pelvis. You'll get to know if there are any long bones that are splinting that needs investigating further. But if you do this part of your trauma protocol, by the time you get the patient back, you know where to channelize your energies to control the trauma. So let's say this is the patient you get from the CT scan. What does this show? Sorry, 1% loudly. So it's an acute SDH. We know it needs to go to the theatre. So again, we go back to our trauma protocol and make sure that we just don't fix on this and take the patient for an SDH while there was, a bleeding chest, a bleeding hemothorax, or a pelvis or a long bone that you missed. It's very, very important. All these get done maybe in the good time of the day, but if it's come at 11 o'clock, if it comes like a day like today, if it's a holiday or a Sunday, these things might not get done. So our job is to make sure these things are set as a routine. So you get all your trauma protocols done, and let's say everything is normal, then you can concentrate on an operative outcome here and good and go and operate it. So neuroimaging is a key that needs to be done within the time. There are set frameworks for that. If there was the GCS was let's say less than 15, but they are lateralizing signs if the GCS is normal. So there is a full threshold for that. And nowadays with cross specialty referrals, our indications for doing the scans threshold is becoming low and low. So our airway maintenance is gold standard. That patient will be intubated depending upon the GCS, either in your ICU or downstairs or in the OT. But you got to make sure that the cervical spine is stabilized, because a good 15 to 20% of head injuries, especially polytraumas, will have spinal injuries. A CT scan trauma protocol will tell you whether there is injury there or not, bony injury, but it tells you nothing about a ligamentous injury. So even if you've got a clear CT spine, you still got to carefully handle the patient during your intubations. The clinical clearance happens when the patient wakes up and you palpate and there are no tender spots. So no CT will tell you a ligamentous injury. So you need to be aware of who clears the spine in your place. A radiology clear CT scan is okay for a radiological clearance, but not a clinical clearance. So airway is paramount, but do mind the cervical spine. As far as induction is concerned, let's say this was a GCS 3. How would you induce this patient? Would he need any drugs? Who would give him, what drugs would you give him to put a tube down? So let's say this guy is now GCS 3 or he was GCS 7, 5 and he's not doing much apart from a grimace of pain and you have to intubate him because his SATs are low. So the message is that a flat patient, a GCS 3, doesn't mean he only needs a relaxant to put the tube down. He cannot respond to you, but his brain is still responding. There is something called CMRO, the cerebral metabolic rate of oxygen. So with every stimulus that you cannot see because the patient is unable to produce it, but his body still has that stimulus, the CMRO2 in the brain will go up and up. If that goes up, the cerebral blood flow will go up, his ICP will go up. So I'm not saying you give him a full anesthetic or an entire dose of propofol or thio to put that tube down, but you have to cut the response. So you have to give a good dose of an analgesic or a sedative drug, considering the hemodynamic scenario of that patient. So a plain relaxant for a GCS3 is criminal. I will go to that extent and I'll say it very boldly. That patient will need some fentanyl, some midazolam, some ketamine or whatever opioid, whatever drug you are used to in a suitable dose for that scenario. Just don't plainly go give a relaxant and intubate that patient because there can't be anything worse than that. Ketamine is fine for ICP, no problem. Enough data for that. So you got the other routine things of cricoids, stable neck, and I would say acute scenarios, use your video laryngoscopes. There's nothing worse than trying 5 times because you will not have your ideal scenario here to get a tube down. So especially if the patients come to you bleeding with all blood in the orifices in the face, you got to maintain an inline stabilization. So get these kits out of the cabinet and start using them so that you know in emergencies how to use them. A video laryngoscope is a great example. Fiber optics in these scenarios aren't of any use. So A, B, C, D, E, you need to get once you've done the airway, you've secured the spine, you've looked after it, then you must have a good oxygenation. So depending upon which guidelines you use, you need to have a 8, 10 or 13, preferably more than 10 kilopascals or more than 110 millimeters of mercury oxygen levels. So initial burst of oxygen is not harmful to the patient. You can bring it down later on once you know that the oxygenation is fine. Remember, we're preventing a secondary brain injury here. So depending upon wherever organization you can titrate it, but you can bring that down rather than worrying about hyperoxygen at this stage. The circulation is important. Now, the circulation principle is predominantly the cerebral perfusion pressure, which is the difference between the mean and the ICP, to put it lightly. As I said in the start, we don't measure the ICP, so we don't know. So what is a common ICP? If the patient is obtunded with a diffuse, let's say any TBI, whether it be extradural, big diffuse axonal injury, what is the ICP number if the patient is obtunded? So it will be elevated, that will be at least more than 25. Has anybody seen ICP being measured anywhere? You have. How was it being measured? Intraventricular. So did you see the number?
Yes, ICP was very high.
Okay, so EVD would not give you a number. Intraventricular would, intraparenchymal would. Was it EVD? So
EVD was connected to an arterial vein and
it was transduced. Okay, so you have a number that is maybe excess of 25. That's why that CPP is 60 for you. That means you need to have a map of at least 85 to 90. That means for a sedated patient who might have lost some blood, who's hypervolemic, it is hard work to get that map up to 90. The message is don't compromise sedation analgesia to generate that blood pressure. You'll have to sedate that patient. You'll have to fill that patient up. You'll have to get that mean arterial pressure above 90, assuming that the ICP is about 20, 25 to 30 right now. Then you get your CPP of 60. The CPP initial targets from Brain Trauma Foundation used to be about 70, 75 when they initially did that, but they brought that down number to 60. Why? Because we were blindly checking the CPP with a lot of inotropes and that was counterproductive. So 60 is about the balance where the outcomes are better. Again, you can use whatever fluids you like. Colloids initially are allowed. Isotonic preferable. If the patient has lost blood, give blood for blood. again, I would say watch for extracranial injuries in the acute setting if the patient has just come to you. Acutely, again, you got to look after the if there are patients been on blood thinners, you got to use the coagulation factors, you got to use rapid infusers. There's one drug which is very cheap as chips, tranexamic acid. It is shown to do benefit if given within 6 hours of trauma. So do get this drug into the patient and it's shown to have the benefit. We hardly practice that and we are guilty of that. I'll talk about autoregulation later on. The CPP thresholds depend upon autoregulation, but assume that your patient initially there, his autoregulation or her autoregulation is intact. So that's why you're going to aim for a CPP of 60. Colloids are okay to be used, and these are the different ways in which you can measure the ICP. So what the lady was saying in the front, you put the right one here is the ventricular catheter. You go straight into the ventricle and you connect it to a manometer. Now that doesn't give you a number, but that gives you added advantage that you can drain the CSF out and instantly bring the ICP down. Now that is the only advantage of a EVD. The downside is a big risk of infection. It's an invasive procedure like others, but the infection risk is the most. That's the only ICP monitor that's done in the country because the surgeons are trained only to do this. We as intensivists don't know any of this, and this is where we need to get to. If you go to the core neurocritical care ICUs of the world, we do all this ourselves. So the EVD gives you an option of getting the CSF out to buy time. This is the subdural intraparenchymal bolts, which are the most common ways of measuring the ICP. There are dual channel bolts as well now in which you can measure ICP as well as the brain tissue oxygenation and the temperature of the brain. So is ICP monitoring useful? Yes, it is useful, and the reason is that we do have evidence. It's recommended on the BTF guidelines, and you have mortality benefit in terms of reduced hospital stay and 2-week mortality. So we don't do it, we should do it, but the rest of the world does do it. The threshold number is, the range is around 22. So 22 to 23 is the number. If it's sustained high, then that needs treating if somebody is measuring it. This was the ventricular drain catheter that's commonly done in our setups. But this is not a continuous measure of ICP, don't be mistaken. It's just a treatment way of buying time, but this doesn't give you a continuous ICP measurement. The ICP measurement, that bolt which I showed, gets connected to a monitor like this. There are a couple of monitors in the market. One is Codman, another one is Masimo's, and they give you a number. So if the ICP is high, we don't measure it, but now that we rely on scans in the clinical pictures and the ICP has, what do? You sedate the patient, you make sure the patient's not bucking on the tube, and you do this. Next time, go and check how many of your brain injured patients have this much degree of elevation. Probably not more than 30%. We are guilty of that. The patient needs to be head elevated at all the time, provided his spine's okay, provided he's in a hemodynamically stable stage. So that patient doesn't need to come flat lying on a bed from the emergency department to your ICU if it's just a TBI. If his spine is okay, his blood pressure is okay, he's not bleeding to death from anywhere else, ask yourself a question, ask your team a question, why is this patient lying flat? This is the quickest way of decreasing the ICP by at least 6 to 7 millimeters of mercury within instantly 10 seconds by putting the bed up. If you go to level 1 trauma centers which do it properly, if they are expecting a trauma patient, they will have the A&E trolley the other way around, because these trolleys would not go head up, the whole head up as in a reverse Trendelenburg. You'll have to break them up. So for a trauma patient, you don't have a spine intact, you can't break them and sit up. So if they are expecting that the spine is also broken and the head is also broken, they will have the whole trolley head up like that. And most of the emergency trolleys will have to be turned other way around to do that part. So that much importance is there to head elevation. The other strategies are sedation, analgesia. If you have an EVD, bring the CSF out and do a repeat CT if you are in doubt. If you still are doubtful about the ICP, the number is still high or the patient has other signs, then you go to tier 2. Now these are not separate tiers in my books, they all flow together, but these are the tiered way of measuring managing the ICP. You paralyze the patient. Again, bottom line rule, You paralyze the patient only when the patient is fully sedated. Even if he's GCS3, he needs to have a sedation. So if you're in doubt, take up this monitor and put that this monitor or the other monitor and see that number has to be there. Before you paralyze a patient, it is a bottom line you to make sure that the patient is sedated. Young TBI patients are notorious for high demands of sedation. Then you can proceed to hyperosmolar therapy. Any choices? Anybody used hypertonic? Anybody's used mannitol? Yes, hypertonic not much. So the world has moved towards hypertonic. We still have on mannitol. Next time do a journal club in your hospitals and see the evidence for mannitol. Mannitol is only going by the history. So hypertonic, the world has shifted. If you don't have hypertonic, don't delay hyperosmolar therapy. Give the mannitol, it's fine, but give it in a proper dose. So at least half to 1 gram per kilogram. That means at least a 250 ml bag of 20% needs to go within 10 minutes. You'll have to work hard. If you give mannitol properly, you don't need to give furosemide. Furosemide doesn't bring the ICP down. If you give an osmotic diuretic properly, it's in its name. Once it causes the osmotic, it will cause the diuresis. So that's for mannitol. What is the most important requirement if you're giving mannitol to that patient who's just come to you? Anything that needs to be in the patient? Foley's catheter. 20% chances it won't be there. And then you realize later on that the bladder is bulging. Nothing worse for a bad brain. ICP will be spiking. As I said, TBI management is simple, but simple things don't get done. So before you put the mannitol, just take the sheet out and see if the patient is properly catheterized, not a condom or anything else. Okay. So mannitol can be given, but think about hypertonic saline. If you come to hypertonic saline, before we finish mannitol, you can repeat it. What are you watching? Serum osmolarities. What is the number? Great. So make sure the patient is well filled as well beforehand if he's been bleeding or losing from anywhere else. So you can give hypertonic saline. 3% can be given peripherally, no central line required. 200 ml, 3% within 10 minutes. Again, you can repeat it. And what are you watching in terms of hypertonic saline? Serum sodium. How much? So 150 to 155. So you can start getting, watching it at 150, 155 you stop. Most of this evidence of hypertonic comes from pediatric TBI patients. But this is where we moved. The 23% is okay for later on when you are in 2-3 days, 4 days DAI kind of a scenario where you can give that as an infusion, but that you will need a bigger lines or a central line. But 3% is the one that you require to give it as an acute setting. Now, if that still doesn't help you, then we wait to tier 3, which is we do a surgery. The problem in India is that we are completely a surgical arm. We see a scan and we do surgery. We don't do medical management of ICP like the proper tier 1s and 2s because our surgeons are not trained to do that. They're only trained to open up and do that. That's the unfortunate part. But it's up to us as intensivists to go and increase the medical management of ICP, which is very, very possible and equally productful. So you can do a decompressive craniectomy. The problem with decompressive craniectomy is, it will come in the next few slides, that the outcomes are okay, but they're not successful. You'll have survivors, but they won't have good functional outcomes. That was all the DECRA and the rescue ICP trials told you. So if you still don't have a surgical outcome, you can sedate them further with a thiocoma or a barbiturate coma. Be very careful of infections and hemodynamic instabilities. Hypothermia isn't of any role. You can mildly cool them to 35-ish, but there's no point aggressively cooling them. You must cool them down if they are hyperthermic. So a brain should not be hot. So if the patient is 38, don't go home till that patient's temperature is down to 37. Every 1 degree rise in temperature will increase the CMRO2 by 4 times, which is not good for the brain. So if the patient comes to you 35.5, leave it like that. It will slowly warm itself up. Don't actively go warming the patient up. But the patient is 38, 39. It's like an emergency. You got to cool that patient down. So these were the surgical trials who said, okay, they were creating a lot of survivors, but most of them didn't have a good functional outcome. So you replicate these trials to India, We do not have neuro rehab, we do not have a social sector. It's a huge burden on the families, and we should ask ourselves, is it the right thing to open the head and do a decompressive for all our TBI patients? That's the question we need to ask ourselves. Now, the autoregulation, as I said, is disrupted in a good number of patients. That's why we moved on from ICP to brain dialysis, microdialysis, and brain tissue oxygenation, because we do not know within the brain where the autoregulation is working and where it is not working. So, to put it very crudely, if you are measuring ICP, if you put the blood pressure up and the ICP goes up at the same time, so that patient's autoregulation is impaired, not working. So it was futile to chase the CPP for that patient. But you can only do this if you're measuring ICP. So you can understand the dilemma of not measuring ICP and treating a TBI patient. So that's the concept of autoregulation. So most of your patients will have the autoregulation intact. So do that. But that's why I say don't go blindly chasing the CPP, because if the autoregulation is not intact, you're blindly going up on the targets of CPP, it might be counterproductive. But that number is small, and we can't rely on that. So we've done A, B, C, D. We manage the brain in terms of decompressive. Now, seizure prophylaxis, most of the TBI patients would need it, but they don't need it for more than 14 days. We don't need to keep giving them on for 3 months, 6 months. So maximum 4 weeks, beyond that stop. They shouldn't be on 2 months and all. Okay. There's a concept of primary and secondary seizures. The long-term seizures. The long-term seizures populations is different. So we don't need more than a week of that. Steroids, no use, harmful. Simple message. So no glucocorticoids are required. They actually will be increasing the mortality. The A, B, C, D, E, F. F is temperature. As I said, you don't need to warm that patient up if it is 35 and above, then leave him alone. But if it is hot, it's as good as an emergency to bring that patient down. So you need surface cooling, you may be needing intravascular cooling if you have those devices. You need ice packs, you need the drugs to cool the patient down, you need fans, everything in an urgent mode, just like you bring a child's temperature down. So targeted temperature mounting is very, very important. Hypothermia in the same time is counterproductive. Aggressively cooling them, all these Eurotherm polar trials show it was of great harm. Glucose management, don't go too aggressive about it. Normal glucose is fine, just like a standard ICU patient. So over aggressiveness gets them hypoglycemics. So that's same as your other patients. Hemostatic is required as the H. That means if they come after blood thinners, if they have stents, if they're elderly, you need to give them the antidote. So FFPs, vitamin K, or a prothrombin complex concentrate. That means you need to do an INR clotting platelet quantitative study. If you have a TEG in your hospital, run a TEG. Long term or not long term, within 3 days, 4 days, if these patients are going to be on the ventilator, early trophic feeding is advisable. Even if their aspirates are high, leave them on low trophic feed. Nutritional support is key. The only one more key difference about sedation practices is in neuro ICU, we don't wake the patient up every day. If you have a DAI patient, we're going to be keeping him flat for 3-4 days. So the daily sedation hold principle of a general ICU doesn't apply there. Every time you wake that patient up, bucking, his neurons will die. So we know that there is swelling in the brain, there are contusions, it will take 3-4 days for it to come down. So we're not going to achieve anything unless there is a blown pupil and so the ICP, if you're measuring changes, there's no point doing daily sedation holds in a neuro ICU. So this is the small ABCD steps for managing a TBI. They are simple steps, but again I say they're not done. Next time see how many head elevated patients you see, how many have a catheter. So the world has shifted from ICP to beyond. We missed the ICP bus a little bit, but we shouldn't miss the next bus. This is a civic statement coming from the critical care physicians all around the world, and what they've done is now they've gone beyond the microdialysis and they've stuck to brain tissue oxygenation. So depending upon where the autoregulation in the brain is working or not working, to solve that dilemma, they've clubbed it with the brain tissue oxygenation. So the units that do ICP, they also do PbTO2, which is brain tissue oxygenation. The normal is about 20 to 24. So they have divided TBI into 4 components, A, B, C, D. So the top line you see here, the brain tissue oxygenation is fine. Only the ICP, A is a standard patient, keep doing what you're doing is normal, his brain tissue oxygenation is good and his ICP is good. So he'll wake up or he'll do what you're doing. But the problem here is you need to see the patient why the ICP is. Is he not sedated? Is his oxygen is down? His blood pressure is low? Does he need paralysis? Does he need CSF draining? But his oxygenation is okay. That means his autoregulation probably is intact. So he falls into this category. This is a patient whose ICP is okay. So this patient in this type C category, he doesn't get treated well by the CPP method. That's why his ICP is okay, but his brain tissue oxygenation is poor. So this patient gets treated by increasing the oxygenation, increasing the PEEP, and probably it's giving a window of you about 6 to 8 hours that he might get into this box. So that gives you a window. That's why this concept is important. This patient needs to go to the theatre immediately because his ICP is very high if everything else has been done properly and his brain tissue oxygen is also low. So this is the new concept of managing TBI, and that is ABCD boxes. So we must get onto this ladder. It's up to our neurosurgeons, and I'll say it's up to us as neurocritical care physicians to do it ourselves and not rely on the surgeons. So in summary, it is all about maintaining normoxia. So normal oxygenation, normal carbon dioxide. In very acute stages, you can bring the carbon dioxide down for a few hours. It's absolutely fine. It will bring the pupil down as well, but not for more than 2, 3, 4 hours. Normal blood pressure, temperature, hemostasis, most importantly, keep that head up. So these things get done properly, you will see outcomes better. And if I have time for a few quick questions, ICP management in TBI, it can be all true, all false types, multi-stem questions. Does it reduce in-hospital mortality? Based on level 1 evidence? No, because it is level 2 or 3 if you got to go by the actual evidence. So ICP management is indicated for a patient whose GCS is 8 with an abnormal CT scan? Yes, it is. It's not indicated for a GCS 8 but with a normal scan. False. Is the mainstay of treatment? No, there are other methods. So CPP is the most common method, especially when you're not measuring ICP, you've got nothing else, you're playing in the dark. But for the core people who got interest in neuro, there's also the Lund therapy coming out from Sweden, which don't believe in the ICP management. But that's for outliers. So you can read about it. Regarding mannitols or hypertonics, hyperosmolar therapy, mannitol is the recommended drug of choice. So the jury, in terms of when you say guidelines, they need the level 1 evidence. So they won't put their number there. But the evidence is shifting toward hypertonic steroid. For your exams, you can't answer that question as yes or no because there isn't a recommendation crystal clear for a guideline. Mannitol increases blood viscosity? False or true? True. Yeah? It will drain osmotic diuretic. 320 you are aiming, you have to stop at 320. Can it increase brain tissue oxygenation? No, it doesn't do anything like that. That advantage is with somebody else. Should not be used in hypovolemic patients. You got to be careful. True. And this is an effective dose. Yes. So you can go increase it up as well, half a gram, and repeat it. Regarding one type of TBI, which is diffuse axonal injury, which is not going to go to the OT, which is going to be medically management, decompressive craniectomy. GOS, what does GOS stands for? Glasgow Outcome Scale. What happens to the patient at 6 months? So they have a criteria called MRS, Modified Rankin Scale. Does it improve outcome? Does it improve survival? So I said there are 2 trials which said all you're producing is vegetables. So you improve survival in terms, but the functional outcome is very poor. Only 40% will have a good functional outcome. Severity of the symptoms are disproportionate to the radiological findings. That's true of this particular pathology in TBI because all you will see is a poor grey-white differentiation, but the patient will be well worse. It's got both a primary and a secondary component. That's yes, predominantly primary, but there is also a secondary component to DAI. Traumatic microbleeds are a radiological marker for DAI. That's true, that's a radiological stem for you. Regarding CPP, cerebral perfusion, the recommended value is 60 to 70. Don't go above that. 60 is good enough. True. Higher CPP is required in patients with impaired autoregulation. No. So you got to be mindful of that. Optimal CP. This is what is the future. This is what, there is another concept which I didn't say anything about, is called pressure reactivity. So it's similar to autoregulation. So optimal CPP means what blood pressure, cerebral perfusion pressure is for that particular patient will be different. And ARDS is a concern in aggressive CPP targets more than 75. That's correct. That's how the target got